On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
You know, we're really excited at this national meeting of scientists and clinicians, the American Heart Association, where we have had an opportunity to vet, for the first time in quite some time, a positive trial in heart failure. It's been a long time coming. This is particularly important because it's in the setting of acute heart failure, and it's using a hormone that really emanates from the experience of women who've been pregnant. That is, the ability to relax their blood vessels under this torrential cardiac output. That hormone has been reconfigured, if you will, as a compound that we now call serelaxin or relaxin, and was tested prospectively for its benefit in the acute setting of heart failure, and there's some very provocative results.
Approximately 1,000 patients with acute decompensated heart failure were enrolled and randomized to either receive serelaxin or not. And in the patients that received it, there was a significant improvement in dyspnea. In addition to that, which itself I think is an important and interesting finding, as it turns out, mortality at 6 months was also favorably influenced with a significant reduction in cardiovascular mortality, and that is exciting.
On the one hand, we saw that the primary endpoint, which is a co-primary endpoint, that is relief of dyspnea, but then also the change in dyspnea over 24 hours, ended up being dissimilar. The relief of dyspnea, yes, but the change in dyspnea over 24 hours, no. And then when we looked at the 60-day outcome, specifically looking at morbidity and mortality, seemingly no benefit, and also no benefit was seen on rehospitalizations, which is a really important concept in today's world. But interestingly, at 180 days, there were 37 fewer deaths in the group that received relaxin versus the group that received placebo. So now we've got some issues that we have to reconcile. A drug that appears to be safe, that allows us to relieve dyspnea, which is why patients come to the hospital, but no real sustained effect on dyspnea, no benefit on this vexing problem of rehospitalization, and an uncertain signal on mortality, powered for a 60-day look. But what about the 180-day look? Is that a look that means something to us? We've been down that road before where we've seen signals and we've chased those signals and haven't always been rewarded. But nevertheless, I think we have to embrace this study as a positive trial. We're delighted to see it in the setting of heart failure, and we hope that this mortality benefit can be replicated. We also need to recall this is for a precise patient population, those that have a blood pressure that's no lower than 120 millimeters of mercury. If all of this comes together correctly, then for the first time we can look at a therapy in patients admitted with acute decompensated heart failure that might be beneficial.
Probably the most provocative thing was to see this late mortality difference, particularly when there was little difference up front during the time of a period of therapy, and treatment was only for a couple of days. And there was no reduction in rehospitalization. So it makes you wonder if this is real or not. You know, we need another study to confirm that kind of result.
The fact that there's symptom relief with side effect profile that seemed quite favorable might be good enough for many doctors to consider using it. That is, we've certainly got patients with bad dyspnea, got to do something for them just for symptom relief. So if that's all that was provided safely, that would still be pretty good. Whether there's really a mortality reduction, I think, needs to be confirmed, but just that tantalizing signal that was seen in this study might be enough to convince doctors to use this drug if it were available just for symptom relief.
One of the striking things about the RELAX study is that it intervened so early in the patient's admission. On average, patients received serelaxin in general less than 7 hours from their admission to the hospital. No trial has ever done that before. And it's the first trial to indicate the possibility that there is a reduction in mortality. So we wonder, are those two related to each other? We're excited about this possibility because we've never thought that time was of the essence in acutely decompensated heart failure. We knew that time was of the essence in acute myocardial infarction. Time was of the essence in acute stroke. But we didn't know that it was of the essence in acutely decompensated heart failure. And if that's true, it'll completely change the way we treat the disease.
How do we really approach mortality trials in the setting of hospitalized heart failure. That's been very, very difficult to do. It's required large numbers, lots of expense, and longer-term follow-up. We may need to recalibrate what we think and what we accept as a meaningful endpoint for studies like this, so we're not paralyzed by this requirement to show that it absolutely saves lives. Let's show that it's safe. Let's show that it helps patients feel better, and then bring it forward in the armamentarium in the correct way.